Oops. Hi there.
Hi.
Good afternoon.
Would you like to test your slides?
Sure. Are you able to see it?
Yes, looking good, my side.
Okay. Just want to set it up as a slide show. Okay, is it changed to
It's
the
good.
slideshow view?
Yeah, thanks.
Okay, and I've just put it in presenter mode so you can still see the slides without my writing.
Yes,
Yeah.
perfect.
Okay, great. Thanks.
We'd like to ask Debbie, you are having a slide set separate from Tanya, is that correct?
Yes, that is correct.
Okay. So she's gonna have to share her slides. She's not on the call, is she?
Not yet.
Okay, I don't see her.
No.
Good. Okay, can you yes?
Would you like to test the intro slides, or are you comfortable
Yes,
with
of course. No,
Cool.
let me just have a look. But Debbie has to unshare. Which is
Okay.
done.
Done?
Yes. Yes,
Okay.
are you good with that?
Yes, advancing nicely.
Okay, perfect. So I'm gonna stop sharing.
I'm going to play the intro video until Tanya joins, and then I'll test her slides with you.
Thank you.
Hi, Tanya. Would you like to test your slides?
Hi, yes, please. Thanks. Can you see?
Yeah, it's looking good. And it's advancing nicely. Perfect.
Okay, thank you. And then is my camera off for the
Yes.
presentation?
It's up to you.
Okay.
You can have it on or off.
No, it told me that it wouldn't allow me to turn it on, which is fine.
It's strange.
Okay,
Yeah, it's
maybe
up to
now
you.
I
Either
can.
way is okay.
Yeah, now I can. Okay, no,
Good.
I'm happy to have it off as well. Oh, I have a Sambas background. Okay, maybe I'll have it on for a bit.
It looks cool.
Okay, cool. Thanks. So I've got 35 minutes for my talk.
I think so.
At least that much, yes.
Oh, okay, cool. So then I won't rush. I feel like my talk
No.
is very long.
Let's just ask Debbie, how long is your talk? Oh,
Maybe
I
she
was
stepped.
just informed that she went to the bathrooms.
Okay.
So we'll just touch base, but I'm sure that she will probably be under half an hour, and if you take half an hour
Yes.
just over, there will be ample time for discussion, Tanya.
100%.
Okay, fine.
And we've got until 5:30 at the latest, so I don't think there should be any issues.
No,
Okay. So then I stay on this link, am I right?
correct.
Yeah, that's correct.
Okay, perfect, perfect. Cool, I'll be back in 2 minutes. Thanks.
Okay, cool.
I'm back.
Okay, perfect.
Ask you, can you hear me talking at this volume?
Yes, I can hear you.
Okay, because the music's very loud.
Yeah,
The
it is.
speakers are not so loud. Okay, if you need me to talk louder, then you must just let me know to turn on my volume. Okay.
No,
cool,
it sounds
thanks.
good.
Okay, thank you.
Good afternoon, ladies and gentlemen. And it is my distinct privilege to, on behalf of the organizers, extend a warm word of welcome to everyone who has joined this meeting to discuss this important topic. Also a word of welcome to the two speakers this afternoon, but more about them in a moment. Just get this on the presenter view. So today's deep dive is brought to you by Blood SA in partnership with the South African Clinical Hematology and Stem Cell Transplant Societies. We would also like to acknowledge the efforts of the organizing or management team that organizes these events. So Professor Estelle Verbrugge, Dr. Gardine Kritzinger, and Dr. Nicolai Smith are part of that outfit. So some housekeeping notes. The recordings of these sessions can be found on the Blood SA website under resources. Click on under deep dive. Also, we encourage interaction and we would like you to please add any questions or comments to the chat box during the meeting for discussion at the end of these presentations today. About TPD points, they will be submitted directly to the HPCSA for each registered South Africa attendee. Please ensure that you attend with your own registered Zoom link and not in a group. You also please are advised to ensure that your HPCSA number is entered correctly when you sign up for the deep dive. And you have to attend for an hour to get a CPD point awarded. For any inquiries about CPD, please email bloodsa at admin@bloodsa.org.za. Then, in terms of the mailing list, if you wish to join, please, you can do that on the website of Blood SA. Go to resources and subscribe to Deep Dive, or alternatively, you can use the QR code that's currently displayed on the screen. So Blood SA also value, and I think also all of the speakers value your honest feedback, and we encourage you to please complete the anonymous feedback survey at the end of the session. So what is on the agenda today? First, we will have Dr. Vaz, and she will kick off by doing a case discussion, and that will be followed by our second presenter, Dr. Tanya Glatt, which will discuss blood incompatibility in autoimmune hemolytic anemia. And she will probably realign our thinking related to the issue of the least incompatible unit of blood in this setting. So about Dr. Deborah Vaz, she's a hematopathologist at the University of Pretoria since 2021. She provides diagnostic services, but also manages benign hematology patients in the clinic at the Steve Biko Academic Hospital. Passionate about teaching and research. And she is currently pursuing a PhD at the Institute of Cellular Molecular Medicine at the University of Pretoria. You can read about her academic interest, but it's actually bone marrow failure, predominantly aplastic anemia, and bone marrow transplant. She also serves on various committees, amongst them International Society of Lab Hematology, Molecular Analysis Committee, Blood SA Aplastic Anemia Working Party, and also the PBM committee at the Steve Biko Academic Hospital. So she has done some scientific writing and also opinion pieces for the University of Pretoria. Dr. Tanya Glatt is a hematopathologist employed by the South African National Blood Service. She oversees clinical apheresis department and also is the director of the Jackie processing facility. She provides oversight to immunohematology reference laboratories where complicated donor and patient samples are referred to for further testing, and that makes her extremely selected, highly selected for this talk. She's an honorary lecturer in the Department of Molecular Medicine and Hematology at the University of the Witwatersrand, and also a research associate in the Department of Human Anatomy and Physiology at the University of Johannesburg. And she's passionate about training of medical personnel in stem cell transplant, transfusion medicine, and immunohematology. I'm not going to introduce the speakers again. I'm now going to stop sharing my slides. But before I do, the topic for next Monday is still to be confirmed. It is a pharma-sponsored event, and the topic will be confirmed on Friday in the email invitation. So without further ado, I'm going to stop sharing my slides, and I'm going to ask Deborah to share her slides, and without any announcement, Tanya will follow it up. Thank you.
Please let me know if you can see my screen and if you can hear me.
We can see it. Just put it in presenter mode, please, and we can hear you clearly. Thanks, Debbie.
Thanks. Okay. Good afternoon, everyone. So I will be starting or kicking off this deep dive session with some clinical cases. First of all, I would like to know, though, how many have been faced with a similar situation. So you have a patient M, admitted to the hospital with severe anemia and symptoms of fatigue, shortness of breath, and jaundice. The hemoglobin level is critically low at 4.3 grams per deciliter. As the on-call hematologist, you receive a call from the peripheral hospital concerning patient M. The blood bank performed multiple cross-matching tests, but all the results showed incompatibility due to autoantibodies reacting with the donor red cells. So the clinician doesn't know what to do, and they would prefer not to transfuse. So my follow-up question to them would be, would you rather deal with a hemolytic transfusion reaction or a dead patient? And this is the reality of the situation, because by delaying a transfusion in an unstable patient, it may lead to a worse outcome. Our first patient is Miss JP. She's a 36-year-old female patient admitted to internal medicine ward at Steve Biko, April of 2024, with a hemoglobin of 4.3 grams per deciliter. The registrar called to advise that the blood bank reported the patient appears to have pan-agglutinin, causing agglutination with all screening cells. She would like an alternative solution to transfusing the patient since she appears to be stable. This was her blood results at the time. Her white cell count was normal, platelets were okay, hemoglobin was 4.3. She had she had a raised MCV and a slight raised MCH, and she had also elevated RPI. So she had features of hemolysis and this very low hemoglobin, as mentioned. The peripheral smear showed macrocytes, polychromasia, spherocytes. There was no red cell agglutination and there was no red cell fragments, but there was a leukoerythroblastic reaction. Following up on those investigations, there were further ones to show hemolysis was present. The bilirubin was elevated, the LDH was elevated, CRP also elevated, ferritin was normal, B12 was normal, and the folate was slightly low. She had a positive IgG for EBV, haptoglobin was low, and her direct Coombs test was positive for IgG as well as complement. So there was a possibility of a mixed autoantibody here. Oh, sorry, to mention as well that the autoimmune screen showed anti-nuclear antibodies, a titer of 160. So what we know from that is that it is a moderate positive result, and it's not a definitive result to say there's an autoimmune condition, but it just adds to the overall clinical picture of the patient. So we'd have to repeat this test and look for other clinical indicators to diagnose as autoimmune disease or added autoimmune disease. So what do we know about this patient? We know that she has a warm or possibly mixed autoimmune hemolytic anemia. She has autoantibodies. She's got a pan-agglutinin with all compatibility tests done at blood bank. She's never been pregnant. She has never been transfused. So alloantibodies are unlikely in this scenario. What we don't know is her extensive red cell phenotype. We don't know her red cell genotype and whether she possibly has an autoimmune condition. So we can possibly say with some certainty that this patient, if she gets a donor which is phenotypically similar in red cell antigens, that we can predict that a hemolytic transfusion reaction is unlikely. The problem comes in with my next patient. So Mrs. EM, she's a 48-year-old female. She's referred to hematology clinic in March 2016 with a positive direct Coombs test. Patient is HIV positive on ARVs with stable CD4 counts and a viral load, which is lower than detectable. Patient is HIV positive on ARVs with stable CD4 counts and a viral load that's lower than detectable. The HB is 8 grams per deciliter. The haptoglobin was low at 0.8. Sorry, apologies for that. Hemoglobin was 8. The haptoglobin was low. LDH and bilirubin were elevated at diagnosis. The patient was started on corticosteroid therapy and subsequently on azathioprine. She's stable, so transfusion independent on the treatment. In November 2021, the HB dropped to less than 8 due to weaning off of treatment. The patient was given 3 units of blood at this stage while she consulted her local hospital, and the treatment was restarted. But then again, in February 2025, at the hematology clinic, she had an HB of 6 grams per deciliter. We suspect she had defaulted her treatment sometime. The blood bank then called me to say there was incompatibility in all cross-matching tests performed due to this pan-agglutinin. It was her FBC at the time, so she had a white cell count of 5.2. Hemoglobin was indeed low. Platelet count of 362. MCV was 106. So also raised. Haptoglobin showed low, which are signs of hemolysis, as well as the bilirubin. And the reticulocyte was elevated at 2.1 for the RPI, sorry. What do we know from this patient? The patient has autoantibodies. She has a pan-agglutinin. She's had previous transfusions at her peripheral hospital. She's had 2 pregnancies, and she's HIV positive on treatment. What we don't know is whether the patient has an alloantibody. So there could be a hidden alloantibody amongst the autoantibodies because she's had 2 sensitizing, or should I say 3 or more sensitizing events. And what we don't know as well is the extensive red cell phenotype workup or genotype of this patient. So with this patient, we can no longer say with such certainty that the patient does not have alloantibodies or that she will not have a hemolytic transfusion reaction. Some of you may have heard the saying, and I think Johan did mention it, give the patient the least incompatible blood. So what does this sentence actually mean? So if you've listened to Blood Bank Guy, he repeatedly says on his various podcasts and lectures that he's given that he's not a fan of using these words, least incompatible. He finds it conflicting, and he says it's confusing to clinicians because the donor blood may look incompatible in vitro tests, but may not cause any incompatible reactions in vivo. So it is just confusing, and perhaps we could be saying rather that we give the patient the blood that's compatible based on their ABO, on their RH and K phenotype, at the very least, the safest. So a full red cell phenotype would obviously be the best, but time may not be on your side here. So as Tanya will elaborate on this further, it will take a long time to do some of these tests. You can find a lot of data also on autoimmune hemolytic testing in Blood Bank Guy. The podcasts found are 85 and 88, and they're very interesting. So in conclusion, what ideally you'd want to have time to call your blood bank and to ask them to do various tests to detect this, the hidden alloantibodies, which Tanya will also elaborate on. Request an extensive red cell phenotype on all suspected autoimmune hemolytic patients. Give your patients or suggest immunosuppressants, and you could give IVIG as well if the patient has an anemia but is stable. And then try and minimize blood transfusions where possible and follow PBM principles. It may not always be possible to withhold transfusions, and time may not be on your side, as I said, but hopefully this would be the correct way to follow. So thank you very much. Tanya, over to you.
Okay, thank you very much. Just if you can let me know that you can see my slides and can hear me.
We can hear you and your slides are visible. Thank you.
Great, thank you. So thank you to the Monday Deep Dive for this opportunity, and thank you to Deborah for that. Today I'm going to be covering some of the topics in autoimmune hemolytic anemia, specifically the classification, the internationally recommended testing, what is available with all the limitations, and then importantly, red blood cell transfusion support in these patients. So it's an autoimmune hemolytic anemia is an acquired group of disorders. It's characterized by autoantibodies to antigens sitting on our red blood cell surface. And it results in the premature destruction of red blood cells and a positive DAT. The diagnosis requires two things. You can't just have autoantibodies, you also have to have the presence of hemolysis as well. And then it's divided up into primary and secondary based on whether there is or isn't an underlying pre-existing condition. Serologically, in the blood bank, we talk about 3 different types: warm, cold, and mixed. Warm is seen most frequently, so up to 70% of the cases are warm autoimmune hemolytic anemia. This is usually polyclonal IgG antibodies. So if you look at the picture on the right, you can see those red cells and the bluish antibodies, those are polyclonal IgG. They bind best at 37 degrees, and usually they're recognizing antigens of the Rh blood group system. They don't often activate complement or only moderately, and therefore most of the hemolysis that we see in this case is extravascular, not intravascular. And how the patient presents is really on a spectrum, depending on how severe the anemia is and their compensatory mechanisms. So it can be completely undetected, can be mild, and in very rare cases, they can have severe anemia. Cold autoimmune hemolytic anemia is less common. We see it in about a quarter of the cases. The most common presentations are what we call CAD, or cold agglutinin disease, CAS, which is cold agglutinin syndrome, and paroxysmal cold hemoglobinuria, PCH. So your CAD is primary, and CAS is due to a secondary to an underlying condition. So you can see the picture on the right. These are usually in comparison to your warm, which is IgG and polyclonal. These are IgM antibodies, and they usually mono or oligoclonal, and they bind best at lower temperatures, so at about 3 to 4 degrees in vitro. They directly fix and activate the complement system, so they cause intravascular hemolysis. Less commonly, they can also cause extravascular hemolysis by opsonization of components of the complement cascade. These patients can either present with a more chronic picture, if the antibodies react at high thermal amplitudes, or as a more acute picture, acute hemolytic episodes if they bind at low thermal amplitudes and then the patient is exposed to extreme cold. So CAD is classified, as we said, as a primary, and it's often associated with the underlying silent B-cell lymphoproliferative disorder, producing a monoclonal IgM. CAS is usually seen as a complication of other diseases, so infections commonly, malignancies, and even vaccination. In children, it's usually, there's an underlying infection, and often by the time we see these patients, they're on the resolving part of the illness. PCH is rare. It's a cold reactive IgG causing severe intravascular hemolysis, and it's often infection related. And then there's this mixed picture in up to 10% of the cases where there's both warm reactive and cold reactive antibodies. And usually in a mix, the cold reactive antibodies display higher thermal amplitude than your CAD or CAS. They can present with very severe and fulminant hemolytic anemia. Specifically, we've seen these cases with a post-allogeneic stem cell transplant, and these cases are very difficult to manage with treatment refractory disease. Okay, so this picture just summarizes what we've spoken about. You can see at the top is your warm autoantibodies. You can see those IgG. They don't agglutinate the red cells spontaneously. So that's why there's that, the green antibody is actually our AHG, or anti-human globulin, which then binds to the antibodies to allow agglutination. So we can visualize that agglutination. So that would be our DAT. So it's an IgG positive DAT with extravascular hemolysis. And then lower down, you can see your IgM, your cold, with your IgM antibodies, and then those yellow circles are actually components of the complement cascade. So that AHG is actually binding to those. So that would be a C3 positive DAT with mainly intravascular hemolysis. Okay, so today we're not going to talk about the pathogenesis of autoimmune hemolytic anemia, but just to say that it is multifactorial. There's definitely environmental components, so often an underlying infection, mycoplasma, EBV, or a neoplasm, sometimes drugs. There's often a genetic component as well. And then we need breakdown of both our central and peripheral tolerance to allow antibodies to recognize self-antigens sitting on our red cells. This table, maybe we've actually discussed everything on this table so far, just maybe the specificity of the antibodies. So in warm autoimmune hemolytic anemia, we said they're usually to the Rh system. In cold agglutinin disease, it's usually to the big I, but sometimes little I. And then in paroxysmal cold hemoglobinuria, it's to the big P antigen. Okay, so what is the workup for autoimmune hemolytic anemia, specifically from a transfusion medicine perspective? Firstly, a hemolytic workup is so important. Often we get phoned in the blood bank to say that we're querying if this patient is hemolyzing, but some of the very useful tests in the hemolytic workup have not been done. So an RPI usually very high if you've got bone marrow reserve, but definitely a normal or a low RPI doesn't exclude hemolysis, a haptoglobin, an LDH, and unconjugated bilirubin. Okay, then from our perspective, a DAT, which we'll talk about, your direct antiglobulin test, and then all the tests I've listed here from 3 to 8, all of these lists use the same technique, which I will go through. So the IAT, the indirect antiglobulin test, so that would be the antibody screen, antibody identification, autoantibody test, an elution test, autoabsorption, and serum dilutions. And then the cross-match test. So that is the standard test that we do before we release any unit to a patient, and also phenotyping and genotyping. Okay, so we are going to look at these tests and see the advantages and disadvantages and when you would use them and what results you would get in an autoimmune hemolytic anemia. Okay, so I'm sure everybody here knows very well what a DAT is, or a DAT. This tells you that you have sensitized red blood cells in vivo. So you just take the patient's red cells, okay, and you add an anti-human globulin and you assess for agglutination. So if a patient has autoantibodies sitting on their red cells, if you add the AHG, those cells will agglutinate and you'll get a positive DAT. You can do either a polyspecific, which includes anti-IgG and C3, or a monospecific, which would either be IgG or C3, to tell you, and you could interpret those depending on what those results are. Importantly, IgM molecules bind to red cell surfaces if against an antigen sitting on a red cell surface, but they are not very stable. And in most of the cases, these IgM molecules fall off. So if we do a monospecific IgM DAT, that could be negative, even though these antibodies are still there. But if we do a C3 DAT and that's positive, this implies prior IgM binding and complement activation. Importantly, all a positive DAT tells you is that you've got sensitized red blood cells. So you've got red blood cells with antibodies sitting on them, or red blood cells with complement components sitting on them. It does not tell you where those antibodies have come from. So it's an immune-mediated hemolysis, but it could be due to alloantibodies as well. So think about an ABO-incompatible stem cell transplant or transfusion, organ transplants, or fetal-maternal incompatibility. Okay, up to 10% of patients with autoimmune hemolytic anemia can have a negative DAT. So what this would be a false negative. This could be for a few reasons. So the autoantibodies could be low titer, so we're not picking them up. They could be low affinity IgG, so even though they are acting, they are bound in vivo, in vitro, they have fallen off. They could be atypical antibodies or antibodies that we're not testing in our first line. Remember, our first line test is just an anti-IgG NSC3. It could be in some cases where all your sensitized red blood cells have been destroyed, or even if this patient has been transfused, and then the red cells that you're testing are actually not the red cells of the patient. There's also cases of false positive DAT, so where you've got a DAT but there's no hemolysis. We know this occurs in infections, definitely testing errors. Drugs can cause a positive DAT. Studies have shown that 0.1% of healthy blood donors have a positive DAT. So these are healthy people walking around with no anemia and no hemolysis. 15% of hospitalized patients can have a positive DAT without any evidence of hemolysis. And in South Africa, we know that 40% of our patients that receive blood transfusions are HIV positive, and 30%, up to 30% of HIV positive patients can have a positive Coombs. And remember that this is in a setting often of an anemic patient. So you've got a patient with anemia, and you've got a patient with a positive DAT. So then do they have autoimmune hemolytic anemia? So that's why it's really important to do your hemolytic workup as well and to interpret this result in the clinical setting. Okay, so what happens if you have a C3 positive DAT only, or so you think your patient has cold agglutinins and you want to know, is this clinically significant in my patient or not? You look at three things, so the titer, the thermal amplitude, and the antigen specificity. They say that if the titer of these antibodies is more than 1 in 64, then it would be clinically relevant. Anything less than that would be cold agglutinins without clinical relevance. The next thing would be the thermal amplitude, and what we know is that clinically relevant cold agglutinins present with higher thermal amplitudes than those that are non-clinically relevant. And then antigen specificity. So almost all of our primary cold autoimmune hemolytic anemias and our secondary forms that are related to mycoplasma pneumonia have an anti-I specificity. So looking at your specificity as well is important. And then very importantly, if you do have a patient with a C3 positive DAT, international consensus recommendations suggest that you have to investigate further. So you have to look and exclude all underlying conditions because you need to urgently treat those in order to achieve regression of your hemolysis. Okay. So then we move on to the next technique, which is a technique that we use in so many tests in transfusion medicine, an IAT or an indirect antibody test, the one that we always use it for when you send us a sample to transfuse your patient is an antibody screen. So in an IAT, we're looking at the presence of antibodies in the patient plasma. So we would take the patient's serum, okay, the red cells, for whatever the red cells, depending on which test we're doing. So in an antibody screen, we've got screen red cells, we've got screen 1 and screen 2. So we've got red cells with lots of antigens on them. And we mix the patient's serum, the red cells, we add an anti-human globulin, and we assess for agglutination. If there is agglutination, we call that a positive screen, and it tells us that the patient has irregular antibodies in their serum. It doesn't tell us what they are, it just tells us that there are antibodies. So the next test we would do is an antibody identification. Again, this is an IAT. And here we're taking, again, our patient's serum because we're looking for antibodies in our patient's serum. And we take what we call panel cells. So these are cells with known red cell antigens on them. So we know exactly what what antigens are sitting on these red cells. And you can see, I'm sure you've all seen this picture before, where you then take your patient's serum, these panel cells, and you perform an IAT and you look for agglutination or not. Okay, and then usually you can use this to interpret the pattern to see what antibodies irregular antibodies the patient has. And I'm sure if you guys look at this picture here, you can easily see on the right is the IAT. The patient is reacting because he's got an anti-K. Okay, so this isn't an autoimmune hemolytic anemia patient, but this is just to describe to you what an antibody identification test is. When we have a patient with autoimmune hemolytic anemia, as Deborah said, it's difficult to interpret these results, and usually everything comes back as positive, or this we call it pan-reactive. So the IAT is positive to all of these cells, and so because the free autoantibodies are strongly interfering with these tests. So the next thing that we can do is an elution test. and to try and see what these antibodies are, or to see if it's still going to be pan-reactive. Okay, so an elution test is also a type of indirect antibody test, and we prepare an eluate of what we're trying to get is the antibodies bound to the patient's red blood cells. Okay, so first we take the patient sample, we take the red cells, we wash them because to remove any unbound antibodies. All we want is the red cells with the bound antibodies. Okay, then they use an eluting solution, so usually acid, to disrupt the bond between the red cell and the bound antibodies. So it frees all the bound antibodies into a solution, which is what we call the eluate. And then you take this eluate, and again, what you actually do is an antibody identification. So you have the eluate with the bound but now free antibodies, your phenotyped red cells, you add an anti-human globulin, and you look for agglutination. So this slide then shows you exactly what we were doing. So it's exact same as an antibody identification. Instead of using the serum, we're using an eluate because we're using we have got the antibodies are on the red cells, off the red cells into a solution, and we're testing that solution with phenotyped red cells. And you can see here on the left, you've got a patient with autoimmune hemolytic anemia. The results is there's a 2+ with against all panel cells when using plasma or serum, and then also with the eluate as well, there's a 3+. So it doesn't tell us any more here. We've still got pan-reactivity. Okay, so what else could we do when to try and investigate further for autoimmune hemolytic anemia? Another test is an autoadsorption test. Theoretically, this is a great test in autoimmune hemolytic anemia. It's going to give you all the answers. Okay. In theory, so it's used to detect if you have any underlying alloantibodies. Okay, so you take the patient's sample where you've got the patient's red cell and the patient's serum. You pre-treat the patient's red cells to remove any antibodies. So now you've got your patient red cells with all its antigens on, okay, and you then go and you mix your patient red cells with your patient serum. Okay, so if you look at the picture here, maybe it's easier if I explain it. So you can see in the first tube, you've got red cells with those black antibodies or the autoantibodies, and then you've got the serum with your autoantibodies, and then you can see there's also those green antibodies, which are alloantibodies, or that's what you're looking for. So you've taken those red cells and you've treated them. So all those antibodies that are bound to them have now been removed. So now those black antibodies sitting on the red cell are now removed. And then you take those red cells with no antibodies on them and you mix them with the patient's serum. So what would then happen is all the autoantibodies in the patient's serum would bind to the patient red cells. Okay, and then what's left in the serum, you could then do an antibody identification, and you could, if that is positive, you could say that the patient has alloantibodies, and because it's an antibody identification, you could even detect what those antibodies are. Okay, so theoretically, it's a really good test because if you do an autoabsorption, you are absorbing all the autoantibodies onto the red cells from the serum, and all that's left is the alloantibodies, and then you can exclude or say that whether you do or don't have alloantibodies in underlying alloantibodies in a patient with autoimmune hemolytic anemia. Okay. There are lots of limitations to this test. As you can imagine, it is not a first-line test. It is not performed regularly. It is not performed even in most referral laboratories, definitely not in your local blood bank. So it will take time. This test requires a huge amount of sample from your patients. So we'll phone you and tell your patient has an HB of 3, but can you please send us 3 more tubes to continue the testing? So it's really not practical or feasible, specifically in pediatric patients. It's not feasible. If a patient has been recently transfused, you can't use it. And then often practically it's just very difficult to do because your autoantibodies are so your red cells are so saturated with autoantibodies. Another problem with it as well is that when they try to remove the antibodies from the red cells initially, those same substances actually denature some antigens of the red cells as well. So Duffy, Cal, and of the MNS systems. So if you have antibodies to these red cell antigens, you won't actually be able to detect that, because this test won't work. It will give you a false result, because those antigens will be denatured and won't actually be sitting on your red cells. So in theory, a great test. In practice, a lot of limitations. Okay. We can also do red cell phenotyping, which Deborah spoke about. So your red cell phenotype is the combination of antigens sitting on your red blood cell surface. These antigens are detected using serological testing. So we have reagent anti-sera. So we have a known, we have an anti-FYA. We mix it with a red cell. If we see binding, then we know there's an FYA antigen sitting on that red cell. Okay. So extended phenotyping looks at a lot of different red blood cell antigens. And then this allows for, so once we know a phenotype of a patient, it would allow for issuing of phenotype matched red cells. But importantly, to have a correct phenotype of your patient, the patient can't have been transfused recently. Red cell genotyping is also an option. This looks at genetic sequence at the loci of blood group antigens, and then DNA analysis is used to determine your blood group antigens. And one of the benefits is that it's not affected by transfusion. You can tell that for both of these techniques, these are also not routine tests done in the local blood bank, so they need to be referred to specialized laboratories. This takes time, and you need more blood volume. Okay, so you can see how all of these tests are going to be a problem if you want to transfuse your patient today, and your patient is very anemic and symptomatic. Okay, another test is what we call serum dilutions. This is a manual test, and basically this is based on the premise that that your autoantibody has a lower titer than your alloantibody. So what you're trying to do is you're trying to dilute out your autoantibody so that your alloantibody will still be there and you can pick it up. So what we do here is take the patient plasma and dilute it and do serial dilutions, and then do an antibody identification, hoping that the titer of the alloantibody is higher than that of the autoantibody. So you've diluted out the autoantibody and you can still see the alloantibody. The advantages is that it's simple to do, it's quick to do, it requires limited technical and human resources, but there's lots of disadvantages. There's limited effectiveness. You could actually get a false result where you're diluting out your alloantibody instead. But what is useful when you do serum dilutions and then antibody identifications is if you see varied strengths of reactions, then that helps us to think that there's possibly an additional antibody other than just your autoantibody. We won't be able to tell what that antibody is, but it does hint towards that. Okay, and then I discussed cross-matching before. So the final step before issuing a unit to a patient is in vitro compatibility testing. So you take your patient serum, your proposed donor red cells, and you mix them together and you look for agglutination. If there's agglutination, that's an incompatible unit. If there's no agglutination, it's a compatible unit. What's very important is when we say something is incompatible, because it's positive, there's varying strings of positivity. And this is important when we talk about the least incompatible unit. This is what we're talking about, where the unit is, where there's different positivities when you cross-match, and what you obviously want to be giving a unit with a lower positive result. Okay, so just to revise, what would our lab results be in autoimmune hemolytic anemia? In our warm type, our DAT would be positive for IgG and possibly for C3 as well, and your eluate reactivity would be pan-reactive. In your cold autoimmune hemolytic anemia, your C3 DAT would be positive and your eluate would be reactivity would be non-reactive. And in your mixed type, your IgG and C3 DAT would be positive and your eluate reactivity would be pan-reactive. Okay, we know that obviously our DAT would be positive. We are using, remember for DAT, we are using patients' red blood cells. Autoantibody test, I didn't go into, but it's actually a very useful test and can be done, a routine test. It can be done in your local blood bank. This is where you take patient serum and patient red cells and you look for agglutination. Okay, so if it's a positive autoantibody test, it tells you that the patient's serum has antibodies to red blood cells in the patient sample. Okay, and then we said in your elution tests, it's going to be pan-reactive in autoimmune hemolytic anemia. If you look at the picture on the left, the third picture, when it says indirect antiglobulin test, this is showing what doctors are so concerned about in an autoimmune hemolytic anemia patient. So this is an IAT test. You can see here the purple are your autoantibodies, and you can see there's also a few alloantibodies. So then these are mixed with phenotyped red cells. Your autoantibodies and your alloantibodies are binding. We add an anti-human globulin and we look for agglutination, and we see agglutination. So we get this pan-reactivity, but actually what's lying there as well is your alloantibodies, which we're missing. So your autoantibodies are masking your alloantibodies. And then we spoke about autoabsorption techniques to detect an underlying alloantibody. Okay, so in summary, first-line tests may not be very helpful, as you saw in the clinical cases, because all of them are positive or pan-reactive. Second-line tests, there are definitely limitations as well. They take time. They require more blood from your anemic patient. They are not readily available, often only in referral centers, or in some referral centers not even performed. They're difficult to perform and very difficult to interpret. And sometimes what you'll find is you'll wait 3 days for a test and it won't be any more valuable. It won't give you any more information than on the day that you had a positive first-line test. So they may not be useful at all. Really, the risks in these patients is 2 things. Either you can't find compatible units, as we saw in these cases, so this would delay issuing blood in a patient who needs to be transfused. Or secondly, which is what doctors seem to be the most worried about, is missing clinically significant alloantibodies causing a hemolytic transfusion reaction. Okay, so this brings us to the second part of the talk, which is transfusion support in autoimmune hemolytic anemia. And as you know, often these patients require red cell transfusions. It's important to also look at other supportive therapies that may assist. If we have identified an alloantibody in these patients, we would only give units that are negative for the corresponding antigen. In patients with autoantibodies, up to 50% of them, so up to half of them, can have an underlying alloantibody. And that is obviously a concern, because you can miss these in your standard first-line tests. But very importantly, if your patient has never been pregnant or your patient has never been transfused, you don't need to worry about this necessarily, because the risk of having an underlying alloantibody is very, very, very low. We spoke about the common practice of issuing the least incompatible unit, which means the unit that is at least ABO compatible and demonstrates the weakest positive result in our compatibility testing. What we often say as well is, so the patient will have a positive DAT and will say, of the units that you cross-match, look at were any of those results lower than in positivity than the DAT, and those are the units that you want to think about issuing to your patient. Recent studies looked at the impact of least incompatible transfusions and have concluded that they are safe and effective in the setting of autoimmune hemolytic anemia patients that require transfusion. Okay. So previous recommendations really discourage red cell transfusions in these patients, saying that it would be illogical or ineffective because whatever antibodies destroy the patient's own cells are just going to destroy these transfused cells. But recent guidelines have really changed this and to say that transfusion should not be delayed in life-threatening clinical situations, even if your pre-transfusion compatibility testing is not fully completed. If you can exclude an alloantibody, then of course you should. But in a patient with no history of pregnancy or transfusion, the risk of alloimmunization is negligible, and therefore an ABO, RHD, and K-matched unit should be sufficient in an emergency setting. Ideally, you want to do more extensive phenotyping and genotyping, but obviously this will usually delay your transfusions. Your patients with cold reactive antibodies, the transfusions should be preheated using blood warmers. Okay, pediatric recommendations are different. They still suggest to limit transfusions only to very severe cases of anemia associated with deterioration of vital parameters, and wherever possible to do extensive phenotyping on your patients and then to give phenotyped units and transfuse only the minimum amount. In patients with an underlying allogeneic stem cell transplant, these patients often have very severe and life-threatening disease, and transfusion should not be delayed in these cases. Okay, so then this brings me to another part of the management of patients with autoimmune hemolytic anemia who require transfusion, and this is called in vivo compatibility testing. So we spoke about cross-matching, which is in vitro compatibility testing. So, so in the blood bank, we are seeing, are the red cells that we're giving your patient compatible with your patient? In vivo compatibility testing is saying, is this blood actually causing a transfusion reaction or hemolysis in my patient? And so what this entails actually is, in the most simple way, is a rapid transfusion of 20 mils from the red cell unit that you plan to transfuse, followed by 20 minutes of observation. Okay, so this is what international consensus recommendations suggest. So you've got a patient with autoimmune hemolytic anemia. You have chosen as the treating doctor to transfuse the patient and to request from the blood bank the least incompatible unit. You then give the patient 20 mils from this unit, and you observe them for 20 minutes. In the absence of a transfusion reaction at the end of the observation period, the test result would be interpreted as compatible, and the transfusion could be continued. Okay, so this is almost what we call like a test dose. So this table shows the algorithm for managing patients who require transfusion in autoimmune hemolytic anemia, and it divides the patients up into whether the transfusion is an emergency, so they must be transfused in the next 4 hours, whether they're temporarily stable, so they must be transfused within 12 hours, or whether it's non-urgent and they can be transfused after 12 hours. And this it breaks down what tests you want to do and what tests you're prepared to wait for in order to prior to transfusing them. What is important is that in all of them, if you look at the bottom, all of them suggest an in vivo cross-match. Okay, so in summary, there are various national guidelines, but there's really a lack of international standardization regarding terminology, definitions, diagnosis, and treatment. Except for pediatric cases, all various guidelines agree that transfusion should not be abandoned or delayed in critical cases, and there's little evidence in the literature for transfusion-induced exacerbation of hemolysis. Recent studies do alert to the risk of clinical decompensation and death when transfusions are too delayed or abandoned. The best approach, obviously, is to give phenotype matched or the most similar phenotype, because this will, number one, prevent reduce the risk of hemolytic transfusion reactions and reduce the risk of the patient developing a new alloantibody. But as you know, this is not always technically feasible. Genotyping as well could be an option, but is not always possible to wait for those results. There's definitely benefit of IVIG administration concomitantly with red cell transfusions, and this is because IVIG could neutralize those autoantibodies due to anti-idiotypic antibodies. So there are two questions: when to transfuse your patient. If your patient has severe and life-threatening anemia, the answer is as soon as possible, except for your pediatric cases, where transfusions are recommended only if vital signs are impaired. But really, prompt transfusion management needs to be assessed on a case-by-case basis, depending on the possible comorbidities and the evolution of disease or the evolution of the autoimmune hemolytic anemia. The next question, how to transfuse your patient, is a bit more difficult because of two reasons. It's going to take time to get all your results, and the risk of if you miss an alloantibody. Maybe in summary, it just talks about which we've discussed already. Red cell phenotyping would be great if it's available. Choosing the least incompatible unit is the way to go when you feel that you need to transfuse your patient. Performing an antibody screen on your diluted serum is also of value sometimes, because that can, although we can't identify that there's an underlying underlying alloantibody is, we could tell you that there possibly is one. But really the prerequisite is close communication between the blood bank and the clinical team. In all cases, in vivo compatibility assessments are recommended at the patient bedside for each unit that's transfused. Recent data and guidelines suggest that the main risk in these patients arises from delayed transfusion management, and therefore it's difficult to define a standardized approach because of the diversity of presentations, but there should be awareness of the risk presented by transfusion delay in adult patients. So really to caution people on the risk of withholding transfusion, to really encourage bedside compatibility testing or that challenge dose, and to always look for and treat any underlying condition. Thank you.
Thank you, Tanya, for that very comprehensive talk. There are some questions that we would like to discuss, and I would like to invite everyone in the meeting to post questions in the chat box, please, so that we can address those. I would like to just speak about the in vivo compatibility testing, Tanya. So the slide that you put up, so for every individual unit that you're going to transfuse, you're going to give 20 cc's or as a rapid infusion and monitor for 20 minutes. What exactly is it that you monitor? I see the slides have spoken about chromium-51 labeled, radioisotope labeled red cells. You're not labeling the red cells, obviously. Are these like clinical features of
exactly.
hemolytic transfusion reaction?
Yeah, so it's really just clinical assessment. It's observation and vital signs. Yeah. So initially, it started by them looking at radio labeled red cells and looking for radioactive activity. Then other studies looked at even free hemoglobin in the plasma, but really just a visual observation, monitoring the patient closely for 20 minutes. Yeah.
Okay, great. So also, if I can ask, from a practical perspective, in terms of logistics, there are multiple types of tests that you mentioned. One of the valuable ones you said was also to dilute the patient's plasma so that you can basically dilute out the autoantibodies and then see whether there are antibodies with different potencies. Is that something that's offered by the local blood bank as a routine, or is it something that you have to request as a clinician?
So you're talking about serial dilutions or
Yes.
manual dilutions, yeah. So no, it's not done. So it's done part of the as almost like a part of an antibody identification, which currently is not done at the local blood banks. So it would be part of a further workup for a patient with autoantibodies. So when your local blood bank picks this up, so you've got your positive DAT, your positive screens, your autoantibody is positive, then they will then ask you to send more samples and will send it to the red cell serology lab where they'll do further testing. So it's not it's not a local test.
Okay, which I think what is extremely important is good communication between the blood transfusion unit and the clinician, and I think that should be basically highlighted in this context. That is bringing us to Tomek's question. He says, is K-typing and RH typing, so phenotyping, available yet at a local blood bank level?
It's currently not, with SAMBS, it's currently not available at the local blood bank level. So it's a referral test to our red cell serology labs. Okay, so we can have that done centrally, and that's for phenotyping. What about genotyping at SAMBS? So genotyping is also available, but again, yeah, at our referral laboratories. So we usually have we start with phenotyping. There would be specific indications for genotyping. Some of the partial or weak, those are the ones that we really phenotype, and yeah, plans are underway for more large scale genotyping and arrays, but really for research purposes at the moment. Then I would like to ask, because you said almost in the single breath about phenotype and genotype that requires large volumes of blood, but why would genotyping really require large volumes of blood if you're using the genetic material from nucleotide? Yeah, so sorry. There's definitely the different secondary tests, should I say, use different require different amounts of blood, but and definitely genotyping does not require a large amount of blood as compared to your adsorptions or elutions. All I mean is usually by the time you want to get to do a genotyping test, we've already used up the tube that was sent for normal compatibility testing. So sometimes it's not often that we have enough sample even left to then send. But yeah, it's definitely not large volumes in genotyping.
Then there's a question posted by Dr. Shah that says, why is the red blood cell full antigen typing important in patients that receive daratumumab?
Okay, so that's a very good question. Thank you. So yes, so anybody who's starting their patient with daratumumab, what they need to do before they start is to send their patient's sample for red cell phenotyping, extensive phenotyping, so that we know the phenotype of this patient. There's actually a whole, because these patients, so daratumumab is an anti-CD38, and CD38 is on our plasma cells, of course, but is also sitting on our red cells. So if you're going to mix red cells with a patient's serum that has anti-CD38 enabled, then those antibodies will then bind to the red cells and interfere with our standard testing. So the screens will all look positive, and it's not because the patient has an alloantibody, but it's because the patient is on daratumumab, or perhaps the patient does have an alloantibody, but you can't detect it. So so ideally to phenotype those patients at the very beginning so that we know what those patients' phenotype is and give phenotype match blood.
Great, thanks for that. Then there's a comment by Estelle. She says, brilliant message, Tanya and Debbie. Quite tricky to negotiate, but seems sticking to the basics is the solution. And I think that that's probably what we need to do in this context.
I have to agree with that. I think so many times we just forget to do the basics or don't look at those results, and sometimes the more specialized tests don't actually add any value in our current in the clinical setting. So yeah, the basics definitely.
And then I see that there are appreciation in the chat box, but I don't see any other questions. If you do have a question, please, you can unmute and speak, or you can type your question into the chat box. What would be the explanation for an auto control to be positive, but a DAT to be negative? We see this uncommonly in our pan-reactive pregnant patients that are having testing for maternal atypical antibodies. And this was posted by Erika Nell of Sun.
Very good question. Let me just read it again. For an auto control to be positive, but a DAT to be negative. I'm not sure. I think that in your maternal atypical antibody, so these are patients that haven't been transfused. So an autoantibody is very useful, but I think in this it's less useful if a patient has been recently transfused, because it tells you that your patient has antibodies in their serum to the red blood cells that they have, but those red blood cells, if they've been recently transfused, could be their own or could be somebody else's. But if a patient hasn't been transfused and you see your autoantibody is positive, then it's telling you that the autoantibodies are to their own red cells. I think that the DAT negative is some of those what we call false negatives. What we often see in cases where the doctor's really querying an hemolysis, but the DAT is negative, is we say repeat the DAT, and we see that even in different laboratories you use different different reagents, where you'll sometimes get a negative DAT and then the next day you're still querying it and it will be positive. So I think that's why we have a different tools in our kit, because sometimes we get positive in one but not in another. But we often do see in these, well, not often, but sometimes when there's negative DAT but you're suspecting hemolysis, when you repeat the test it will be positive.
Thanks, Tanya. When you started off, you talked about DAT and how frequently it's positive in hospitalized patients without any phenotypic features of hemolysis. I think you mentioned almost like 20%. So we also know that it can be positive after the following transfusion. So Dr. Shah wants to know if the patient is recently transfused, what would be the appropriate time to do a direct antiglobulin test? Are there any guidelines to guide this?
Sure that there are specific guidelines. Yeah, I think I don't know if anybody else wants to give their opinion on what they would do in this setting. I think it's important to interpret that in the setting of whether they've been recently transfused or not.
Yes, and I think it needs to be clinically significant in
Yeah.
terms of what are the clinical features and whether it is something that you consider in terms of hemolysis.
And also, please to interpret that in the setting of the other results of the hemolytic workup.
Perfect, thanks. Are there any more questions or comments? I don't see anything new coming up. Some more appreciation was expressed earlier on. Great, if there's nothing more, then I think we may log off the call. And I would like to take this opportunity of again thanking the organizers and also our presenters for, I think, a very succinct and appropriate type of presentation. So thank you for that. Great. Thank you, everyone. You may log off.
Thank you. Bye-bye.
Thank you. Bye-bye.
Thank you. Bye-bye. $15,000 the airplane. The plane. Why is this not letting me?